So I have a couple announcements. First is we already have 309 persons and counting that have signed up for the Zotero database. So that's very exciting. So thank you to you online. Thank you to everybody here. That's fantastic. So keep doing that. If you have an article that you know and you have in possession, or you're like, oh, I just read that last week, I'm going to go find it, send that article to research@culinarymedicine.org, and the team will review that and look that through. So that's going to be really helpful for that. One other announcement is that I've been told that yoga has been a big hit. And we were missing yoga earlier today, but we intend to make that a regular feature at future conferences. So thank you for that feedback and for that support with that. So we want to make sure that we have that as part of our wellness approach to our movement each day on that. Remember also to, if those of you that had posters today and for the weekend, remember to take them down by the end of the day today. So that you can take them with you back. And I'm not sure, I believe the poster sessions, the announcements will be made on that soon, either later today or tomorrow in terms of the evaluation on those. And what do you all think about the Mediterranean diet score? Did everybody see that this morning? This is a game changer, I think. I think the ability of and accessibility of that for our patients, for us as practitioners, in order to guide our patients, the ability to have them customize the menus. One of the things that I get when I talk to patients when they're walking out of the class is, they're like, well, how do I make my recipes for the week? Or well, how do I put things together? So now having an additional resource that I can help, they can use to guide and put those recipes together from the database that we have, I think can be a tremendous aspect for that. So I think this can be very helpful as well on that. And then the last thing I want to announce is too is that as chair of the clinical practice committee, those of you that have any interest in participating in a clinical practice committee, I want you to make sure and reach out to me. We're always looking for new energy, new members, and new ideas. So reach out to me directly at david.dungan@dooley.com. That's david.dungan@dooley.com. So look forward to hearing from you about that. We will not have a June meeting, but we will a meeting again on the second Wednesday of July, and that is virtual. So you don't have to travel for that. All right, so let's get into the afternoon session. I have the honor of introducing our first speaker, Dr. Ed McDonald, who you heard on the panel earlier. He's a trained chef and board-certified physician dedicated to improving the health of individuals and his communities through nutrition education. His experience includes actually training hip-hop and spoken word artists to be health educators, as well as training barbers to be health educators in our communities to extend that accessibility for good health for those that have challenges with that accessibility. He completed his chef training after he did his residency, I think. Is that right? And then did a fellowship in gastroenterology after that. He has additional information and interests that are listed in his bio. He's at the University of Chicago, so I'm glad to have a fellow Chicagoan join the team today. And he's going to present on helping patients navigate the food landscape. One other thing, I have a new fun fact, and I'm going to, Dr. McDonald has to do that too. I was in a music ensemble when I was 18 that performed on live Austrian national radio in Vienna. So that was something, a fun fact. So Dr. McDonald, you have to give us a fun fact too. All right.
All right. Thanks so much. It's really a pleasure to be here. And I really want to thank Timothy Harlan. So if there was a Mount Rushmore for culinary medicine, Timothy Harlan would be on it. And he's really been an inspiration. Years ago when I was a resident and I first got interested in this, I mean, this was a little while ago. There were only about 3 names that came up when I was searching people who were doing culinary medicine. It was him, John LaPuma, and David Eisenberg. So it's really humbling for me to have the opportunity to present here in front of him and his organization. And also I have my chefs here that I work with and colleagues, Janine Wise and Jenny Wu, and I will talk a little bit about them. So, fun fact, let's see, I'm a Chicagoan, I'm into music, DJ. I was telling somebody a story last night how I met Beyonce when I was a high schooler, and she was a high schooler. So there was a party at Olympic Skate World in Richmond Park, one of the south suburbs, and there was this young girls group that was performing. This is like 1995 or 96 or so, and it just happened to be this group, Destiny's Child. So me and my friends, we're skating with them after they performed in the middle of the roller skating rink, and one of them was Beyonce. Like, I tried to get her phone number, and I got nothing. I didn't even get a fake number. I'm like, you could at least gave me a fake number. But she went on to marry Jay-Z, which, he's a billionaire. I'm a multi-thousandaire. But, God's not through with me. So let's get into it. We're going to talk about navigating the food landscape, and I want to use a patient experience to kind of highlight while we're having this conversation. If I could figure out how to change these slides. Let's see, what am I pointing at here? Right there. All right. We're working on it. Let me turn it around. Now, I've done this before. This is not my first time. So you got sabotaged. I got sabotaged. There you go. All right. All right. So I am a trained chef, as they mentioned. Let's see. Work at the University of Chicago. We have a program called Real Docs Cook, and this is a picture of us. We were doing a barbecue competition, and I started a program with one of my classmates from culinary school, Chef Janine Wise, who was here in the audience. And we do cooking classes all throughout Chicago, specifically in communities that have some of the lowest life expectancy in the city. And we also have a cooking program where we are looking at how our classes affect the gut microbiota. And that experience has really led University of Chicago to actually help us build our teaching kitchen, which is actually being constructed right now. And I do want to take a time out, to be honest with you. So they are building our kitchen. It's going to be in a new cancer pavilion. And just the other day, one of the construction workers actually fell off of a scaffold and passed away. So out of respect to the efforts that they've been putting in, I just want to have maybe like a couple seconds of silence out of respect for this person who passed away. Okay. So why did I choose this path? And it really came from a 59-year-old veteran who was one of my patients when I started my clinic as an intern at the VA hospital at Northwestern. He was divorced, unemployed, and he couldn't cook. He also had diabetes, fatty liver disease, obesity, and a mild stroke. And he was eating hot dogs every single day. Now, he mentioned that he didn't have any money and that there were no grocery stores in his neighborhood, and he just could not cook. So I had to help him really figure out how to navigate the food landscape into which he existed. So I want to do a couple different things. I want to define food swamps, food deserts, food apartheid, and also define food insecurity and discuss some principles for navigating the food environment, okay? So first things first, whenever I approach patients or even approach some of our research projects, I think about theoretical frameworks. One framework in particular is the 5 A's. Okay, so the 5 A's really come from the obesity literature, but you can apply it to anything. It originated in smoking cessation literature. One of the ways I use it with food insecurity or navigating the food environment, or even in my weight management clinics, it becomes really a model that is easy to follow. So the first A is ask. I think before you talk to anyone about food, you have to ask, is it okay to talk about food? Because food is very personal, okay? And sometimes there are people who don't necessarily want to talk about food because people may have shame, people may have stigma. Sometimes trauma can affect the way people eat. So with that, I think it's important to set the ground rules of the conversation. And if people don't want to talk about it, that is okay. Like, they don't have to talk about it. But I think giving people that space actually helps you develop more of a rapport and a little bit of mutual respect. The next is assess, and then advise and agree and assist. So another model is the health belief model. So the health belief model, what I like about it, it focuses on a couple different things. It acknowledges how background can impact behavior, but it also embraces motivation and in people's perception of obstacles, okay? So if you're trying to encourage healthy cooking, like, you have to not only say, well, you know, here's how you cook, but you have to be aware of what obstacles people may be facing. And if anything, you have to be aware of their perception of the obstacles, because that's really the problem. It's not just the obstacle, it's how they perceive it. So, you know, for instance, you may have somebody who has all the resources in the world, but if they feel like they're too busy, that in of itself, you know, may not necessarily may be a reason why they're not cooking, as opposed to food insecurity per se. But it really comes down to their perception of time. That's the problem. So I've seen people, you know, they may not necessarily work a job, but they feel like they're too busy. And it's not my place to judge and say, well, you have all the time in the world. It is my place to help them navigate that perception, which is very different than applying my own perception to what they're dealing with. You see what I'm saying? And same with perceived benefits. So there are some people who may not necessarily understand the perceived benefits of eating a healthier diet. Another model that's good to be aware of is the socio-ecological model. So this model really identifies how the nutrition environment and also economic factors and cultural factors and individual level factors can impact human behavior. And what we deal with in the hospital, or at least in a lot of these classes, we're really trying to encourage behavior change to some degree, or even maintaining healthy behavior. And I think in that process, we have to understand all the different factors that could play a role in some of those behaviors. Another model that I like to share with people is trauma-informed care. So I am on the south side of Chicago, and as a Chicagoan, unfortunately, I see a lot of people who experience trauma. And also as a gastroenterologist, trauma comes up a lot in our GI clinics. So one part of trauma-informed care that I always like to emphasize is really being sensitive to cultural issues, to gender, and also historical issues. So whenever I give recommendations or even listen to a patient's story, like, I also keep in mind how some of these issues can impact their behavior. And that puts me in a position to be very open-minded and less biased, and really open to, really embracing their experience. And I think as a chef, as a clinician, as someone who helps people navigate nutrition, really trying to understand and embrace why people are doing what they're doing puts me in a better position to actually assist them in navigating what they have to navigate, because it forces me to really understand and try to get into their shoes. So another concept that I like to impress upon you all is really understanding your why. Like, why are we helping people navigate the food environment? Why is this even important? A lot of us are busy clinicians or busy healthcare practitioners. We have 10,000 other things to do, but why? And for me, I think why is really the foundation of building authenticity, trust, and transparency. So one of the reasons I tell people why I like to do this is because it's clear that food is associated with life expectancy. So one study out of JAMA looked at the 17 leading risk factors for life expectancy or early mortality. And what they found was, even beyond cigarettes, food was associated with, had the strongest association with early mortality. And most of that was deaths from cardiovascular disease. So me coming from Chicago, where there's huge disparities in life expectancy, this is something that's near and dear to my heart because these are disparities that I bore witness to growing up and also as a current Chicago resident. So I practice medicine on the south side of Chicago. This chart right here from Robert Wood Johnson shows life expectancy differences based upon the train line that serves the neighborhoods. So on the south side where I practice, the life expectancy is about 69, which is markedly lower than other neighborhoods in Chicago. Another study out of NYU Langone Health demonstrated that in Streeterville, the average life expectancy for someone born there is about 90, whereas in Inglewood, it's only about 60. So this 30-year gap in life expectancy is the largest gap within any city in America. So for me, you know, connecting food and life expectancy is very important to me. So one of the reasons why I talk about food is because ultimately I just want to see people live longer. Like it doesn't have to be any more complicated than that. But when I talk to my patients about food with that in mind, people understand my true passion. They understand why I'm having this conversation, and that puts me in a place where I'm actually more trustworthy to some degree. Now, another why. I like to share more of a personal story. So I am a nutrition expert. I provide TPN and I do tube feeding through the hospital. Sometimes I do work with pediatric populations. And occasionally I go down to the burn unit at University of Chicago. And every time I go down to the burn unit, I hear a nurse say, "Oh, not again." And I question the nurses. I'm like, well, you know, what's going on? So what do you all think is the most common reason for pediatric scald burns on the south side of Chicago? Anybody? What's that? No, it's ramen noodles. Yeah. Yeah, so we did a study at University of Chicago. 1/3 of our pediatric burns comes from the ramen noodle packages. The median age was 5 years old, and a majority of the kids were unsupervised, and 90% were African American. Now, you know, a question you have to ask yourself, well, why is an unsupervised child at 5 making ramen noodles? And the answer is you really have to look at some of the structures involved. So University of Chicago, our patient population is 26% experience poverty, 15.8% experience unemployment, and about 17.5% have food insecurity, okay? So when you look at all those factors, there are social determinants that actually can put people at risk for being age 5 cooking ramen noodles by themselves. And when you look at it through that perspective, it all starts to make sense. And that perspective is really called structural competency, okay? So I think if you're going to help people navigate the food landscape, it's good to have some terminology, okay? Especially if you're trying to do culinary medicine as a research effort or research project. So the definition of structural competency is basically an approach to clinical training that aims to improve health outcomes or health care by directing attention to the structures that are underlying some of these social inequities that we're seeing. So when you look at Chicago, let's take a look at the percentage of people who are drinking sugary beverages at least daily. So there's marked differences based on some of the different ethnic groups in Chicago. Same thing when you look at who's consuming fruits and vegetables. But let's look at some of these behaviors through a structural lens. So in Chicago, about 11.2% are food insecure, and this is from the city as a whole. But certain neighborhoods, especially on the south side, my patient who was eating hot dogs every day came from Inglewood. So the rates of food insecurity are much higher in Inglewood, up to about 35 to 57% of people in Inglewood may experience food insecurity. Okay, so there's different structures involved that are necessary that may contribute to someone eating hot dogs every single day. So food insecurity is also concerning because it definitely can have an impact on the foods that we eat. So we had this experience, this challenge where we were using foods from a bodega or a corner store, okay? Well, food insecurity is associated with higher rates of ultra-processed food consumption. And ultra-processed foods, as Dr. Harlan alluded to earlier, ultra-processed foods have health consequences, okay? So one study that demonstrated that ultra-processed foods, consuming them daily was associated with increased mortality, specifically if you were consuming at least 4 servings of ultra-processed foods daily. As such, many people have argued that physicians, health practitioners, have an ethical obligation to ask about food insecurity. Now, one way to ask about food insecurity is really the simplest way is the hunger vital sign, okay? 2 questions, not a whole lot. The questions are, did you worry your food was going to run out, or did you worry the food that you bought was going to last? Pretty straightforward. And one slide that didn't get in here, the best way to ask this is not in person, but it's really in a written questionnaire, okay? So they did a study where they looked at differences in people admitting to food insecurity in person via a verbal question or versus a questionnaire. So more people were significantly likely to say they have food insecurity if it was in a written form as opposed to just asking, which I get it. It makes sense. If you're sitting in a clinic and someone you just met, says, are you food insecure, or are you worried your food's going to run out? They may not necessarily want to share that information or feel comfortable sharing that information. So I think it's easier just from a human behavior perspective to just, say no in that setting. But when it's written, people have a higher likelihood of actually admitting and opening up, because I think it does eliminate the possibility of judgment and that face-to-face shame. So the question comes from a USDA study where they looked at markers of food insecurity and also food security status, be it low, very low, or food secure. And those 2 questions had the highest association, strongest association with food insecurity. And that's essentially why we have the hunger vital sign. Now, how do you help patients navigate food insecurity? One way I do this in my clinic, I actually help people apply. So a lot of my patients who do screen positive, instead of me just, having them sign up in clinic, and sometimes I do this, people can sign up right here. So the state of Illinois, we have a website where people can apply for all different types of benefits. And for my patient population, I have essentially a MyChart link. So I send people kind of a standardized MyChart message who screen positive, and just send them that link, and it doesn't really take any time on my behalf. I don't have social workers in my clinic. I don't have community health workers in my clinic. If you do have those as an option, they can be very helpful, but a lot of people may not necessarily have all those resources or even the time to actually bring those resources to the table. And what I found was just sending people a simple link is very helpful for a certain population. And then there's also getting people connected to a food pantry. So I like this website here. So this list, essentially, you can search all the different food pantries in the country, and something in your local neighborhood, your city, wherever you at, this has all the food pantries that are available. So here is the Feeding America website again. So this is, really just a great resource. Or you can start a food pantry. So in 2010, medical students at University of Chicago, they started their own food pantry. It's called Feed First, and they started the pantry essentially with very limited funding, and they partnered with the largest food pantry in Chicago. And through that partnership, we were able to open up locations throughout the hospital. So this is what it looks like. So we have one location in the emergency medicine department. We have a location in OB-GYN, DCAM. We also have a location in some of the internal medicine clinics and also in our GI clinic. And it's a judgment-free, safe space. So people can just come and get whatever they need. So you don't have to sign up for anything. You don't have to ask our permission. The food is available to whoever wants to take it. And if anyone's interested, there is a website. So the Feed First website, we actually have information on how do you start a food pantry within the hospital. So it's really kind of a step-by-step approach to how do you do it. So how do you find your local food bank? How do you connect with your local food bank? How do we restock it? How do we manage it? So it's really just a great resource overall. Now, when you're helping people navigate the food landscape, you really have to have an understanding of what is the food landscape and why the food landscape is what it is. And I put landscape in quotation marks because the word landscape implies that what we're experiencing, or what people are experiencing, came about naturally. And it didn't necessarily come about naturally. I mean, there were a lot of factors and a lot of policies that created the food landscape in which many individuals have to navigate, both in rural and urban settings. So one thing I want to talk about is redlining in particular. And this is something that's very relevant in urban communities, especially in Chicago. So in Chicago, we have thousands of vacant lots. And for me as a Chicagoan whose family has been in Chicago probably since 1920, when my great-grandfather came up during the Great Migration, I remember asking my grandparents about, vacant lots, and like they would always tell me about these stories, how there used to be movie theaters in Bronzeville and like car dealerships. We drive around and my grandmother is like, this used to be the club where I saw Nat King Cole, and it's all vacant lots. Okay, so these lots, they didn't become vacant just because, a fire or some natural disaster. There were policies such as redlining that actually led to some of these lots becoming vacant. So redlining essentially was a process that was started in the 1930s where the U.S. government decided which neighborhoods should receive loans. And they used the process basically by saying a neighborhood that was majority African American, you should not receive a loan for a mortgage in those neighborhoods. So those neighborhoods were graded as grade D, whereas neighborhoods that were desirable were graded as grade A. And this has a huge impact in terms of the food environment, but also the makeup of many of our cities, because the neighborhoods that were redlined, essentially you could not get a mortgage or a loan to live there. So that changed the makeup. Before redlinings, a lot of these neighborhoods were not necessarily as segregated as they are today. Many neighborhoods in Chicago, such as Inglewood, looked very differently even 50 years ago compared to what it looks like nowadays. But what essentially happened once the neighborhoods were redlined, not only did a lot of people flee those neighborhoods, but subsequently grocery stores and other businesses could not set up shop in those neighborhoods. And the grocery stores actually engaged in what's known as supermarket redlining, where it was easier just to go out to the suburbs and make these mega stores than it was to actually maintain some of the stores in some of these neighborhoods. So a lot of the neighborhoods left with all the other people who left during redlining, and it just changed the food landscape of a lot of these neighborhoods. And here's one good example. So this example really shows the impact of neighborhoods that weren't redlined versus neighborhoods that were redlined. So before 1930s, the majority of these neighborhoods that could have been redlined, these were the grade C neighborhoods that were essentially had a mixed population. Their population was more or less the same as far as diversity in terms of number of African Americans. But then once redlining began, again, you can see a lot of those neighborhoods differed significantly. skip over this. And this is one of the reasons why I prefer the term food apartheid. Okay, so food apartheid was coined by the food justice activist Karen Washington, and she, along with many people, felt that calling these neighborhoods food deserts or any of these natural terms doesn't really do the processes that led to these neighborhoods looking the way they look. It doesn't do that process justice. Okay, it implies that, you know, just like the Sahara Desert just kind of happened to some degree. But what happened in some of the quote unquote food deserts in Chicago and other neighborhoods was not a process that happened on its own. It's a process that was driven by financial factors, policy, a lot of decisions, a lot of social factors, including racism. So in Chicago, right now in the present day, one of my colleagues, Mari Gallagher, did a study looking at the prevalence of Chicago's food deserts throughout the entire city, and they were almost exclusively in African American neighborhoods. Now, Chicago's not alone in that. A nationwide study found that, in general, predominantly black neighborhoods have about 52% as many supermarkets as compared to white neighborhoods. And in the study, they defined supermarkets as a store that has 7 checkout aisles or less, or more. Now, the term food desert did not originate in the United States. It actually originated in Scotland in the 1990s. So in Scotland, they were doing a study of tenements, and what they found was in their tenements, which essentially was their public housing, that there were lower life expectancy, and they wanted to figure out why. And what they found was in these tenements, there were no stores of fruits and vegetables. And the Public Health Commission at that time argued that the food deserts are actually contributing to a loss of life. So what is the USDA definition of a food desert? It is essentially a low access tract where there's about 500 people, or about 33% of the population live more than either in an urban setting, a mile from the nearest supermarket, or 10 miles from the nearest supermarket in a rural setting. And I like to point that out. So you can live in rural America. You could be surrounded by farmland. If you don't have access to a car and the supermarket is, 10 miles away, like technically you live in a quote unquote food desert. And I have driven through middle America. I mean, there are some parts in central Illinois, if your gas tank is halfway empty, it might be a problem. You might not see anything for miles, okay? And that's gas, let alone food. So it's reasonable to talk about the food landscape because about 12.8% of the population in America lives in food, quote unquote, food deserts. And this is around almost 40 million people. So that's a significant number. So a significant part of our American population experiences this food landscape that we're talking about navigating. So one thing I do want to point out is that the impact of living in a food desert is fairly controversial to some degree. It's also understudied. One of my colleagues at University of Chicago, John Pierre Dubé, who's an economist, he did a study where he looked at 60,000 households and their purchasing habits, and even looked at the impact of opening up a grocery store in certain neighborhoods. And what he found was even when prices and having a new grocery store was controlled for, purchasing habits didn't really change all that much. And he argued that about 91% of what people consume is really driven by preference as opposed to just access to some degree. Another study that was done in Baltimore where they looked at behaviors within public housing, and they were looking at dietary habits of people who lived in a food desert who had a car versus people who did not have a car. And what they found was even when you had access to a car, people were still consuming the same stuff. So even though you had the opportunity to shop outside of the quote unquote food desert, you were still eating some of the same food that was in the food desert. So I think there's other worrisome factors in the food environment that's worth discussing. So, my patient was living in Inglewood, which is a neighborhood that's been designated as a food desert, but is also a food swamp. And again, these are not naturally occurring phenomena, but these are terms that are thrown out there. So I think it's good to be aware of the terminology. And food swamps are areas where energy-dense foods overwhelm the healthy options. Okay, so for me, I have a weight management clinic, and I'm on the south side of Chicago. I have to help people navigate this, and one of the concepts that I talk to people about is stimulus control. Anybody familiar with stimulus control? So stimulus control is, you go to work and it's somebody's birthday and they have birthday cake everywhere. You didn't go to work thinking I'm going to have 2 slices of cake, but you see the cake and you want to get some birthday cake, okay? So that's just a work setting, okay? What do you do when your environment actually stimulates you to eat? What do you do with, when on your way home from work just to get home, you have to go by, Harold's Chicken, Shark's Chicken, McDonald's, Burger King, Popeyes, a liquor store. Like your whole environment, every corner is something that's stimulating you to eat something that's not necessarily the healthiest. How do you navigate that? And in my clinics, I mean, I literally ask people where they live, and we're drawing maps and going, giving people different routes home, unfortunately. Um, Another study I wanted to point out, it came out of New Orleans, and what they found was similar to what my patient was experiencing in Inglewood. This is really a problem that's not only isolated Chicago, but it affects other cities. So they found that in general, in predominantly black neighborhoods, there are about 2.4 restaurants per square mile, which is significantly more than what you'd find in a predominantly white neighborhood. So how do you help people navigate this food landscape? So I feel like we spent a lot of time talking about the food landscape, but how do we navigate it? So one tool that I like is actually Instacart Health. Okay. So Instacart has the ability for one institution to provide fresh funds to patients. Um, there are care cards where you can actually order food for your patients. And then what I have set up is storefronts. So my patients, when they come to me, I can give them a link to my storefront, and I already have, foods that are healthy, that are cheap, that are accessible, affordable, already set up. So people who need to navigate this, all they have to do is click a QR code, and they have access to everything that I've already, quote unquote, approved in a way that's, culturally competent and friendly, and also price friendly. So I think this is really been helpful for me and my patient population because it makes things easier. And then for a lot of my patients who don't have access to transportation, having groceries delivered really has been a game changer since the pandemic. So pre-pandemic, I mean, I'm talking to people who are hopping on multiple different buses, who are carrying groceries by hand. And, it could be a 80-year-old person who has to do this, and they have limited mobility to begin with. So sometimes, just because of limited mobility, even though they may have financially the resources, but mobility-wise, they can't even get around. So this has really been a game changer as far as helping out with transportation. Then there's produce prescription programs. So my colleagues here, Jenny Wu and Chef Janine, we work with a farm, Windy City Harvest, and they have a program called Veggie RX. And with Veggie RX, it's really a partnership between the local farming communities and also a hospital where people can now get prescribed healthy produce at a discounted price. Then there's medically tailored groceries. So medically tailored groceries falls, and produce prescription programs, they both fall under the category of these food as medicine initiatives. So medically tailored groceries, the Food as Medicine Coalition is a great website that has collection of all the different medically tailored grocery programs throughout the country. So that is a place that you can go to figure out what's local to you. So if your own institution does not have medically tailored groceries, I think that's an excellent resource that you can use to figure out other nonprofits that may be in your area. And another option is really just doing cooking classes, okay? So as I mentioned, we have our program called Good Food is Good Medicine, but we're looking at how the classes affect the gut microbiota. And what we found was, even though we may not necessarily give people access to groceries, and we're not necessarily, doing produce prescription programs for everybody, just by giving people the education and the skill set needed to eat a healthy diet, that actually has a huge impact, even when they don't have access to a lot of resources. And we actually found that impact by looking at their stool bacteria. So we have a couple different cohorts where they come through and all they get is information, education from us. And that education and information and the cooking classes over 6 weeks has the power to change their gut bacteria. Like, we're not changing their resources, we're not changing their finances, we're just changing their knowledge and comfort. And that in of itself can change behavior. So for my patient who didn't have any money, didn't have any grocery stores in his neighborhood, and also couldn't cook, I started off by giving him some recipes, okay? So he was doing hot dogs every single day for every single meal, and I asked him what his favorite vegetables were, and he basically said he liked broccoli. So I gave him a recipe on how to cook broccoli, and he took it and ran with it. So I saw him maybe about 3 or 4 months later. He lost about 30, 40 pounds. Like, I thought this man was dying, okay? Like, I was panicked. I'm like this little intern. I'm like, oh, did I forget to, do a PSA? When was his colonoscopy? Like, I got to order a CT scan. Like, I'm freaking out. I'm melting down. And then I asked him again. I'm like, sir, so what have you been eating? Are you still eating these hot dogs? And he was just like, nah, I just eat broccoli. So one, that taught me a lot of lessons, even in terms of my dietary education. And we had to liberalize his diet a little bit to include some protein. I mean, as much as I love broccoli, you can't really live off broccoli all by itself. But it showed me the power of food, okay? Because when he came in, his blood pressure was actually a little bit lower. When I first saw him, we had him on insulin. We had him on multiple blood pressure medications. We checked his blood sugar, and he was in clinic, I mean, his glucose was on the low side. So I realized that I was actually able to peel off some of those medications that he was on. So we got him off insulin. He was only on metformin once I was done with him. He also got off multiple different blood pressure medications. I think we still kept on a hydrochlorothiazide, but before he was on, 4 different medications, including clonidine. So I mean, this was like really hard to control blood pressure. And all we had to do was just change his diet, and some of these factors that were more difficult to control all of a sudden became controllable. And a lot of it had nothing to do with me. I mean, he saw plenty of excellent cardiologists and, endocrinologists, and I'm just like a lowly intern, fresh out of med school, just took the boards, still trying to figure out what it means to be a doctor myself. But like, I knew you couldn't really live and be healthy if you're eating hot dogs every day. I knew that much, and we really helped him navigate the food landscape to change some of his diet. All right, so I'm going to leave, and we can open the floor to questions.